Good afternoon, all the participants. My name is ธนากร the first year fellowship trainee of National Cancer Institute Thailand. Today, I would like to present the 142nd Inter Institute Conference. A 60-year-old housewife from Nakhon Pathom, and her medical coverage was Universal Coverage Scheme. Her chief complaint was palpating vulvar mass for 1 month prior to admission. She felt a mass at her right labia majora with a little bit itching. She did not complain about bleeding, abnormal discharge, dysuria, bowel habit change, or weight loss at all. The past history: she had a history of squamous cell carcinoma of cervix stage 3C1, status post CCRT and ACRT. Completed treatment on January 9, 2020. After complete of cervical cancer treatment, she visited at OPD for her physical and pelvic examination, along with pap smear every 3 months, and the results were normal. She had no underlying disease, drug and food allergy, history of smoking, alcohol drinking, previous surgery, family history of cancer. She got married and had 2 daughters. The last one was 25 years old. Her menopause age was 50 years old. Physical examination. Her vital signs, general appearance.
ขออนุญาตค่ะแบตหมด
Her vital signs, general appearance, HENT, lymph node status, heart, lungs, abdomen, and extremities were all normal. Pelvic examination. After 10 months, disease-free interval showed a fat condyloma-like lesion measured about 3 cm wide by 4 cm long at her right labia majora, and a hypopigmented lesion measured about 2 cm wide by 2 cm long at her left labia minora, as shown, and leveling the size of biopsy with green crosses. She had vaginal agglutination upper to middle from RT effect that could be breakable. Her cervix did not show any cross lesion at all. The uterus and endosa, cul-de-sac, and rectovaginal examination were all normal. The differential diagnoses were metaconus vulvar cancer and recurrent cervical cancer. The first one was metaconus vulvar cancer after cervical cancer stage 3C1 diagnosis because of presenting vulvar mass more than 6 months after cervical cancer diagnosis. Data from retrospective study of gynecologic oncology in 2018 showed the second most common metaconus anogenital tract cancer was vulvar cancer, and the median age of diagnosis was 65. When cervical cancer was squamous histology, metaconus vulvar cancer was more likely to be squamous histology, odds ratio 9.3 statistically significant. A 5-year overall survival rate after metaconus vulvar cancer diagnosis was 46%. According to the result of this study, the risk factors of metaconus vulvar cancer usually occur in women at age more than and equal 60 years, squamous cell carcinoma subtype, and a history of radiation, which presented in this case. The 10, 20, and 30-year cumulative incidences of metaconus vulvar cancer were about 0.2%, 0.3%, and 0.5% respectively. The second one was recurrent cervical cancer at vulva due to locally advanced cervical cancer and pelvic node metastasis, which had a poor 5-year overall survival and oncology outcomes. The risk of recurrent disease was shown to increase incrementally on the basis of most distant level of lymph node metastasis, but recurrent pattern commonly occur in lymph node or combined site metastasis. Vulvar metastasis occur with a low incidence of only 1% was published in 2017. In this case, show only single lesion at vulva. Therefore, both vulvar biopsy was done, and the pathology report were squamous cell carcinoma non-colonizing on the right and VAN3 on the left. Her chest sleeve was normal. CT whole abdomen with contrast show an enhancing lesion at vulva, size up to 2.54 cm wide by 2 cm long, without definite mass at cervix or significant intra-abdominal lymphadenopathy. The patient was found to have both invasive and pre-invasive lesions after cervical cancer diagnosis, so the most likely diagnosis was metaconus bowel cancer. Therefore, the plan of treatment in this case was modified radical posterior vulvectomy with bilateral line of dissection, and we performed sentinel lymph node biopsy for academic purpose. We chose the radical surgery due to good survival outcome. There are many advantages of sentinel lymph node biopsy, such as shorter hospital stays, decreased incidence of wound breakdown, cellulitis, chronic lymphedema, recurrent erysipelas, and 5-year glide recurrence rate only at about 2.5%. Unfortunately, the mortality rate of glide recurrence in undissected glide node is as high as 90%. Sentinel lymph node biopsy. The indications were squamous cell carcinoma subtype, unifocal lesion with size less than 4 cm, depth of invasion more than 1 mm, no clinical glide node enlargement, and no evidence of metastasis. The procedure should be understaged using serial sectioning and immunohistochemistry if sentinel lymph node biopsy is negative or routine H&E staining. The sentinel lymph node biopsy is identified by radiocolloid and blue dye injection. The patient should be able to follow up for ultrasound of glide every 2 months for the first year for early detection of enlarged nodes. And this slide shows the landmark papers. The safety and oncologic efficacy of sentinel lymph node biopsy in bowel cancer was confirmed by 2 prospective studies, the GLIDE 5 and GOG 173 studies as shown. From the recent retrospective study conducted by GOG in 2021 show that ICG was promising with a very high sentinel lymph node detection, and the rate was 100% in 6 studies. The detection rate of sentinel lymph node mapping in bowel cancer were about 87 to 100% by using indocyanine green or ICG, 31 to 100% by using blue dye, 90 to 100% by using radioactive technetium-99 sulfur colloid. Indocyanine green has the advantage of being non-ionizing, safe, informative in real time, and allow direct optical guidance for surgery. Moreover, another report published in 2020 compared ICG to the gold standard. The sentinel lymph node detection rate was about 100% by using radioactive technetium-99 sulfur colloid alone, 96% by using ICG alone, and 91% by using radioactive technetium-99 sulfur colloid with blue dye combination. Utility of indocyanine green with near-infrared fluorescent imaging has been increased for sentinel lymph node mapping since 2012, the green line. The operation of this case was modified radical posterior vulvectomy with sentinel lymph node biopsy for academic purpose with bilateral glide node dissection. The sentinel lymph node biopsy was performed with indocyanine green injection with a concentration of 2.5 mg per ml diluted with water 10 ml. In dilation 1 ml each point immediately before surgery. In these pictures, with the use of indocyanine green, 1 sentinel lymph node was found each side. The pathology report for bowel tissue was squamous cell carcinoma with a depth of invasion less than 1 cm. It's very early invasion and free of tumor for all margins. Both glide sentinel lymph nodes and both glide nodes were all negative for malignancy. So the final diagnosis was metaconus bowel cancer stage 1B, second post modified radical posterior vulvectomy with sentinel lymph node biopsy with bilateral glide node dissection. After cervical cancer stage 3C1, second post CCRT and PCRT. The plan of treatment was surveillance for pelvic examination and cervical cytology every 3 months for 2 years, then every 6 months until 5 years, then annually. Imaging as indicated based on symptoms or examination findings suspicious for recurrence. She was advised for periodic self-examination and given education regarding symptoms of recurrence such as vulvar irritation or visual change. I'd like to express my sincere thanks to all the audience for your kind attention. Thank you very much.
Thank you very much for your presentation, Dr. Kanika. We have about 2 minutes left. Anyone have the question or suggestion? From my opinion, in this case, we have learned about that you have present the metachronous of vulvar carcinoma. I want to ask you that how about the pathological report of the vulva at the left side? That you mean first you said that the biopsy show VIN.
It's only VIN.
It's still VIN.
VIN, no carcinoma.
And that you said that carcinoma is on the right labia.
The right side, yes.
That's right?
Yes.
And what you think that how about that you apply the sentinel lymph node examination in the case that have previously radiated, like in this case, because previously this case was diagnosed the cervical cancer squamous cell carcinoma of the cervix. Said
yes.
And post both external and internal radiotherapy. And that means, is there any interference of the radiated area when you apply the sentinel lymph node? Do you understand me?
No.
Normally that we apply the sentinel lymph node technique in the case that in naive from the treatment such as surgery or maybe radiation. But in this case, it's about only 1 year after radiated. Is right?
Yes.
That have the lesion on the vulva. Only I raised the issue of when you apply the sentinel lymph node, maybe it might be false negative, something like that, in the radiated area. And also in this case, in another option that might be the lesion still at that time of you diagnose the cervical cancer, because the times that have shown of the clinical is short, very short, about only 1 year.
Yes, just 10 months. This is free interval.
10 months, yes.
10 months, yes.
It might be maybe coexisting lesion. At that time you have diagnosed, or might be very strongly expression. Only 10 months left after treatment. It shows the clinical of the vulvar lesion. I mean that it must be realized that when you see the patient have diagnosed of squamous cell carcinoma of cervix, you might clearly examine the physical examination of the patient, maybe HPV-related associated lesion in the genital tract. You understand me?
Yeah. Yes.
But however, this is the study case, or maybe the case that we have learned about the maybe differentiate between metachronous or recurrence in the clinical setting, that we can learn about the natural history of the disease.